Okay, thank you again joining us for wrap-up interview. We have a great session in this morning on the new frontiers in cardiology. So we have great distinguished speakers for that session. And so we have some summary and in-depth discussions in this session. So Dr. Sun, you're going to introduce the speaker first and
Yeah, Dr. J.K.O. is here to tell us about the future, the present and future of the echocardiography, and Dr. Faxon in the area of interventional cardiology, and the Chandrasekhar in the aspect of the intravascular imaging.
so, right,
So-
J.K.O.
So, would you briefly summarize your talks done in this morning to the attendee who did not participate in our session?
Sure. Well, my talk was about echocardiography, and just like any other technology, when I look at this history and how it's developed, really was a culmination of some interesting discovery, which led to some interesting applications, and then serendipity of some opportunity, and then passion for some people. All those combined together, I think that really developed echocardiography. So it was discovery of producing the ultrasound wave by applying the electricity in 1800s, and that led to the imaging of cardiac structure first. And it came from the just line of structure we call amplitude structure first, and then they saw the potential of the particular technology in cardiac imaging. So they move on to, M mode and two-dimensional echocardiography, look at the structure, and then borrowing the concept of Doppler and 1600s of a concept, and we're able to measure the blood flow velocity for Doppler echocardiography. And then get that pressure gradient. So we, were able to now do all the hemodynamic measurements that used to be done by cardiac catheterization, by now not invasively by echocardiography. And after that, we are able to also measure the velocity of tissue, and then that is very helpful for diastolic function assessment and color flow imaging. So when I look at all the development, at least echocardiography from early 1970s, every 3 or 4 years, there's something new. M mode, 2D, color flow imaging, Doppler echocardiography, contrast echocardiogram, and tissue Doppler imaging, diastolic function assessment, contrast echo. Now what's happening is I think we probably reached about 90% of what echocardiography really can do clinically. And then all this application being explored, especially with the interventional colleagues and cardiac surgeons, we are able to help them to do more procedures more safely. And so I think it's integration of the imaging with our interventional cardiac colleagues, surgical colleagues, been very, very important. And until now, echocardiography was used by the people who are really expert in it. They train for 2-3 years and doing all this hemodynamics. But I think in future, this will be miniaturized and probably play a role of initial screening that we are doing with the stethoscope. So I think we're going to go for the 2 different tiers, one for the very comprehensive imaging, and the other one will be somebody who wants to use for the point of care, for the emergency room, your practice office, and then critical care and things like this. So I think, it's really fantastic journey for the last 50 years, and then continue to evolve. So
We are already at 80% of what we can achieve. So the next thing that can happen is going down.
no, I don't think so. It's maintaining, and I think the technology 80% up there, but the number of people who really using that technology is not 80%. I can still see that many of our interventional colleagues who are trained in the hemodynamic area with intervention, they may not even believe what we produce. They still want to get pressure measurements by cardiac catheterizations, and you know, I think we need more training, and then we have to make sure that people understand what we can do with 80%. So I think it's a continue to go up in terms of people who uses it, and then practice with the echocardiography.
Then what is your frank opinion in the area of artificial intelligence and fourth industrial revolution in echocardiography?
Yes, I already know some people that now accumulating the really big data. I met someone with Australia that they have data from 500,000 people's echocardiographic data. So now they train the machines, and also we're creating a software. So what's going to happen is, you know, echocardiography, as you know, if we have the 20 different variables, we may be able to obtain only 15 sometimes, only maybe 10. And this artificial intelligence, what's going to do is that you provide the available data, and then from existing data from, you know, several million people with all your similar clinical characteristics and other parameters, they come up with certain diagnosis for you.
Yeah.
So I think artificial intelligence will really help us to make the process much easier and the less variable. So I think, but I think still going to be a lot of input needs to be done by the echocardiographer and cardiologist. So I don't think it's going to replace our job, but I think it's going to make it much simpler and nicer.
So you think the job opportunity for the young cardiologist in echocardiography is secure?
Very secure.
Secure.
No
okay.
problem.
Let's move on to Dr. Faxon.
Okay. David Faxon, would you summarize briefly for your talk? And
Sure, happy to. As we talked this morning, we've come a long way in 40 years when interventional cardiology really started. As I mentioned, Charles Daughter was probably the father of interventional cardiology, a radiologist who first did a peripheral angioplasty in 1965. And that followed by Andreas Grunzig, who really is the father of coronary angioplasty. At that time, we were happy with a 60 to 70% success rate, a failure rate of restenosis of 40 to 50%, and an application of the technique in maybe 5% of patients with coronary artery disease. That was the state of the art in the early 1980s. And now we are 70% of coronary artery disease with success rates that are 95, 98%, rarely fail. The rates of emergency surgery have basically disappeared, when we used to have surgeons on standby, and now they don't even know we're doing the procedures. So there's been tremendous change over a relatively short period of time. And I think much of that is related to amazing developments in technology, which have allowed us to do things we couldn't do before. I think the development of over-the-wire balloon systems, bare metal stents, first generation drug-eluting stents, now second generation drug-eluting stents, which have smaller struts, more flexible, better for more complex stenting procedures, and now changes in the polymers that attach the drugs to the stents. They're now biodegradable. They're luminal, rather they're not completely around the stent. All those, although they sound like minor changes, are actually fairly major and add up to incremental improvements and long-term outcome with patients. So clearly we've been able to reduce the three major complications or limitations of angioplasty with technology. But those three problems still exist. They aren't gone away. So we still have a problem with unfavorable anatomy that limits our ability to do complete revascularization in multi-vessel disease. Chronic total occlusions that are the newer techniques with antegrade and retrograde procedures have improved the success rate significantly, but that's in patients who we select to do. And the vast majority of patients with chronic total occlusions we can't do, and that problem needs to be solved, so that's still an issue. Stent thrombosis rate's gone down dramatically, but we still need dual antiplatelet therapy to prevent the problem. And maybe it's only 1.5%, but it's still a meaningful complication with a high mortality rate. And then, of course, restenosis and very late restenosis, probably due to neoatherosclerosis, is a problem that we've recognized is a long-term problem with patency of the vessel. So those problems all remain to be solved in the future. The other major wave of interventional cardiology is in structural heart disease, and that's been as exciting as the balloon angioplasty era. As you know, the first valve was put in by Cribier in 2002. By 2005, Edwards had started experimental studies and then clinical trials, and that and the core valve, the two major valves in the United States, have been approved since the mid 2011-2012 period. The growth of that area is astounding. I'm sure it's the case in every medical center in the world. It is now the treatment of choice based on randomized clinical trials in patients with very high risk, extreme risk, and high risk, and now intermediate risk based on randomized trials, are patients who are getting TAVR over surgical valve replacement. And there are 3 randomized trials in lower risk, non-high risk patients. We all expect that those trials will show equivalency, certainly in the short term. It's questionable, and I think the one answered question there is, what's the long-term durability of the valve? We have lots of good data about the durability of surgical valves, but we don't have really long-term follow-up of the TAVR valves, although so far they look pretty comparable, even up to about 7 years. So I think we're going to see that they are equal. And if they are, then I think it's going to be hard not to use it in the vast majority of patients. I think the emerging area that's most exciting is the development of devices to treat mitral valve disease. This is a much more complicated problem. The one device that's available for mitral regurgitation, the mitral clip, is technically difficult. It takes a long time to do them. It requires a lot of integration with imaging to do it properly. But when applied to patients who had functional mitral regurgitation rather than degenerative, the success rate's very high. Outcome seems pretty good. So I think it's going to find a place there. But the future needs to go for angioplasty devices, remodeling devices for the left ventricle, and of course, mitral valve replacement, like TAVR. And that's in its infancy at the moment.
Thank you. In terms of a second generation of drug-eluting stent, actually efficacy concern is we achieve, almost a plateau. Personally, I think it's quite good. And the still remaining issue is any meta-analysis is clearly demonstrate any mortality benefit in terms of compare over medication even, right?
Yes.
In PCI side, and so we have to compare with cavity concern, and so still we are struggling, some part. And so
no, I mean, I think the if you look at the volume of PCI fell about 2006 after the COURAGE trial was published, and I think that was a correction that was correct. Because you have to ask yourself every time you do a PCI, why am I doing this procedure? I'm not doing it to fix the lesion. I'm doing it to make the patient better. And so I think we have appropriately questioned when we should be applying angioplasty to patients. It's not the ocular dilation reflex, as Don Bain used to call it. It's fixing a patient, that you're doing something to a patient that's going to improve the long-term outcome. Our greatest benefit from surgery has always been in multi-vessel disease, particularly left main and 3-vessel disease, not even 2-vessel disease. So that's an area that angioplasty has never been able to show a mortality advantage in randomized trials. So I don't think we will until we can adequately treat patients with 3-vessel disease. Right now we can't do that because we can't treat the chronic total occlusions. And therefore we're always going to be incompletely revascularizing patients. So that's a technical hurdle that we've struggled with from day one. But I'm optimistic that we are learning a lot about total occlusions with these techniques of really just dissecting the artery and then looking by IVUS and seeing what we're doing and what's going on in there. I think we're learning much more about what we might be able to do in the future than, and we're not there, but I think we will get there.
Bioobservable, scaffold actually is a kind of a revolution, but conceptually, right?
Yes.
As you know, observe disappeared,
Yes.
vanished, and so.
Yes, it's a very
what about-
attractive idea.
Yeah. What about the future, perspective?
Yeah, I think it's a great question because we're all a bit disappointed because the Absorb stent, the BVS stent, looked very good in early trials, had excellent acute results. IVUS and OCT data showed the stent dissolved and went away with time. Coronary function returned to normal, remodeling returned. So all kinds of things you would want to see with the stent. The unfortunate part is that when looked in clinical trials, there was a higher rate of stent thrombosis and a higher rate of target lesion failure. And that's disappointing because that was one of the hopes that these stents would be able to do, is to allow us to back off on the long duration of antiplatelet therapy. But I'm still optimistic personally, because I think we're in a almost not even the first generation, an even earlier generation of these stents. The Absorb was the first, it was a polylactate stent. As you know, it's a thick stent, it's a big stent, it's 150 microns in diameter, the struts are, versus 60 for some of the current metal stents. So it's a much thicker stent. It's very difficult to negotiate. It's hard to expand up against the vessel wall, and all of those technical things lead to a worse outcome, which is exactly, I think, what we've seen in the clinical trials. Remember, the difference in stent thrombosis, although threefold higher, is 1% in absolute terms. So it's not huge. It's not like it's 99% of patients don't have a problem with it. But we can't really go forward with a stent that's not going to perform as well as our second generation drug-eluting stents. So I think we need to perfect it better. And there are a lot of new ones coming along that look like they have better profiles. And I think the magnesium stent is pretty far along in clinical trials, showing less thrombosis, both experimentally and in the clinical trials to date. So I think that might be something that will actually come to clinical use.
So another, revolutions in intervention cardiology, I think, a TAVR procedures for severe aortic stenosis patients. So simply 10 years later, do you think the TAVRs totally replaced, saver procedures?
Totally agree with it. I wouldn't go that far, because there are obviously reasons that you can't do certain patients. Certainly if you don't have good access. It's interesting that even though we've gone from extreme risk down to intermediate risk and now low risk, the average age of the patients that were doing the procedures in the TVR registry is 84. And it's still 84. It hasn't gone down. So we're still doing very elderly patients who have all the complications of elderly patients. Whether it will ever get, the durability issue to me is the one issue that I would need to have before I'd be comfortable having a 35-year-old man with aortic stenosis, and I know he needs the valve for the rest of his life.
Sure.
Because even if he gets a bioprosthetic valve, I know it can do a valve-in-valve if it gets in a problem in the future. So I have options for myself. So I think if it's durable, I think it will take over. I really do.
Thanks, David. Yeah. Okay, the next talk, Dr. Chandrasekhar, really thank you for your comprehensive talk this morning. So would you briefly summary for that?
Sure. So intravascular imaging is in a very exciting era. The technology is galloping. Computerization is kind of allowing us to look at big sets of data very fast and very easily. So the evolution, if you trace it from 1988 onwards, when the first IVS catheter was introduced in man, it was brought to answer two fundamental problems of angiography. One was angio just looks at the lumen and it doesn't tell us about the wall. We are not very good at looking at a lumen and predicting stenosis. That's why we needed a better method to size. And around the same time, Glagau showed that the wall starts remodeling outside, which was completely obscured for angiography. And then, as we saw in the previous talk, in 76, 77, stenting came out, and then by the time 10 years later, we saw complications of stenting. We didn't know how to size it, and IVS played a big role in that. So those were the 2 or 3 reasons why it took off initially. And then people started to understand wall biology, and then you needed a technique to look at the wall. And so that's why IVS came, and subsequently OCT came, which looked at wall even better. And then techniques like near infrared spectroscopy came, which allowed us to look at lipids. So that was the primary driver for evolution of imaging. Having said that, if you look at the data published on intravascular imaging, it's explained biology beautifully. It tells about wall, it tells us about what factors in the plaque or the wall tell us bad things are going to happen. It also starts predicting who will do better after intervention or not. But it's a work in progress, and newer questions are starting to arise. And the present, that which brings us to the present state of intravascular imaging, it addresses 2 or 3 fundamental buckets, if you think. Sizing stenosis better, understanding intervention optimization before, checking after the intervention is done that your stent has sufficiently expanded, and then if a stent fails down the road, find out the mechanism, whether it's neoatheroma or very late stent thrombosis. And then finally, the biggest thing to my mind is the ability to understand the disease itself. Complex coronary artery disease is something we are constantly wrestling to understand, and that is where it is standing right now. Practices are adopting intravascular imaging to various degrees. If you go to France, they don't do that much of intravascular imaging. As you come more to the Far East, they use it in pretty much majority of the patients. And probably the reason for this is lack of major clinical outcome-based trials, and which is where the next frontier is. What's coming up in future is very exciting. 2 or 3 things are going to happen. We are going to image faster. We are going to image better in terms of penetration as well as resolution. And then we are going to marry this with sophisticated technologies, either in the form of hybrid imaging, where more than one technologies come in the same small 2 French or 2.5 French catheters, and which overcome limitations of each other and trying to get us a comprehensive package of understanding the biology. This will also be paired with a lot of high level computing as the horsepower increases. Eventually the goal may be to just create a whole 3D volume of the artery, and then you can slice and dice whichever way you want. You can find out lesion characteristics automatically based on image fingerprinting, which is like pattern recognition based on databases, and you can say this particular pattern is associated with this particular prognosis. So very exciting future down the road. What are the stumbling blocks in imaging? What can derail this pathway? One would be a drop in research funding, which has driven all these fundamental innovations. A lot of OCT, if you remember, came from the MIT lab, Swanson, Fujimoto, Tierney, all were funded by NIH. So that drops, industry may not pick up that. That would be one of the drawbacks. And then insurance payers will start asking questions about outcomes more and more, because as cost of technology increases. So that is something which we can handle. We may not be able to handle the funding part, but we can handle the data part. As a group, if we start producing more outcome-based data, that will strengthen imaging. So I see a lot of exciting things down the road. And hopefully 10 years from now, we would be using it pretty much routinely to change outcomes.
Right. During the last almost two decades, we've learned a lot from the invasive, imaging. So, however, that in the worldwide, the real practice concerns still functions less than 10% penetration, the imaging less than 20% penetration, more than 80% physicians actually they did their practice with angio-guided procedures. So we have to do some things, improve the procedural outcome and clinical outcome. So what do you think the future our imaging role for that?
Right. So I am a big believer in imaging, and I think it really does add value. But part of the reason why it hasn't penetrated is we have to kind of do a better job of explaining what it can do and what it cannot do. So in some cases, the technology has galloped faster than the evidence following it. And so some practices don't adopt because of that. Some practices don't adopt because of cost. And then some just don't want to spend the time doing a perfect job. They just want to do it and get into a throughput. So I think the two things that will change is, of course, better technology will make it easier, right? And so if you remember 10 years ago, OCT used to be like something very scary to do. You had to occlude the artery and so to stop the blood flow, and now it's so easily done. So technology is one thing which will improve penetration, but I think the day we get one good randomized trial showing major change in outcome, the whole picture will change. And I think the future is based on outcomes. Those days are gone when we would say, here is a picture before, here is it after, it looks beautiful. That's not it, it's what happened down the road. And once we show that, especially in the areas both of you are excited about, BVS and its all the problems associated with it, maybe imaging is the answer as the technology evolves. So I think we need to do a better job providing foundational data to show that this makes a real difference.
So practically, could you imagine in terms of, there are many modalities in terms of grayscale obvious, OCT, near spectroscope and so. Could you imagine the combined, the modality, we can measure the vessel size and the inner characteristics.
So that is the holy grail, right? The closest we have got to at this time is IVIS plus near infrared spectroscopy, right? That has had first in man studies and shows that you can measure the lipid in the plaque which you are imaging with IVIS. But the holy grail might be, before the holy grail, IVIS plus OCT is nearly there, right? There are animal studies on this and there are early studies, but it hasn't come to a common clinical fruition. But that's a very exciting technology. It is a perfect marriage of two things, right? IVIS has penetration, OCT does not, so they kind of help each other. IVIS does not look at calcium well, OCT looks at calcium beautifully, so it helps you prep the lesion better. OCT does not look through a heavy lipid core, IVIS looks through it, so that is beautiful. So these have complementary things that can marry each other very well, and people have now come to catheter sizes into 2.7 French or lower, at least in animal studies, combining them together. One big hurdle is OCT is galloping so fast that now in the heartbeat OCT, in one diastole you can record 4,000 frames and your pullbacks are very fast, whereas IVIS doesn't record at that frame rate. So there is some computing issue involved there, but eventually this would be a very exciting technology where if you think about it, you can look at the plaque, you can look at beyond the plaque, you can deploy based on IVIS, right? So that gets rid of the OCT problems of not being able to see external elastic lamina. And then after you deploy the opposition and all those things, whether the stent is correctly expanded, OCT shows you all that. And so there is a lot of beauty in that, and we are getting there. I mean, that's the next frontier very easily.
Great. Any Dr. Sun, any?
Oh, Dr. Chandra Satan. If there is a discrepancy between the imaging data and the physiologic data, which data do you prefer to weigh on?
Right, absolutely. So this is one place where seeing is believing may not be completely true, right? So I would frame it a little differently. It depends, believe for what endpoint, right? If you're talking about size of the vessel, right, the anatomic imaging is obviously believable. If you are believing whether the blood flow in that vessel is reduced for a given stenosis, then you need physiology, correct? So they're asking completely different questions, right? So we cannot say one is good, one is bad. Where the problem comes is physiology has moved on and given you outcome data, right? FAME, DEFER, FAME2, right? OCT, intravascular imaging is catching up, but it doesn't have that stronger data, correct? And so that is what we have to catch up with. But it's probably not a correct equivalency to say is one better or the other. It depends on
tipping toward physiology data.
Depending on the question,
Okay.
right? So.
Chandrasekhar has already mentioned about the FFR, physiology and anatomy is a little bit different one. So practical concern simply, and treat or not treat concerns, we have to consider physiology first, FFR first. FFR, the absolute number actually, has influenced in the total imaging variables too. And so I think, treat or not treat concern is based on the physiology. And however, just Chandrasekhar mentioned about, how big, make a, stent size, stent optimization concern, we are imaging more, preferable for that. That is my
Right.
personal intervention is the side, right?
And the boundary is kind of getting gray, right? So now with CT-FFR and computational fluid dynamics, you can get physiology, you can get wall, you can get blood flow quantitation, right? And so somehow they are kind of merging into each other. And now you have OCT CFD also, right? You can use computational fluid dynamics to get FFR through OCT catheter.
You can do that with angiography.
Yeah, even angiography.
Without doing anything else. So I wondered if you wouldn't even go a little further with your fusion imaging idea and say, what if I combined, angiography can give you FFR or IFR. You can get CFR, but you can get FFR, as well.
Yeah, right.
So you can get FFR with angiography. You get geometry for an angiographer. Interventionalist, you need to know when there's a bend and turn and twist, and you need to have a three-dimensional.
Right.
The problem with IVUS is you get a picture that's straight across. So that's not the way the artery is. The artery is going like this. So if you fuse all those images together, let's imagine you had that capacity. So you have angiography, you have total geometry, you superimpose all the images into a three-dimensional picture that's live and real, and you could then twist it around like a CT as you're negotiating something through. Wouldn't that be the ideal? That'd be fantastic. Then you get everything. You don't have to give up anything. You have everything all together. I don't know if you can do
This
that, but
more in detail. FFR, the floor actually was influenced by very different, morphologic factors, such as even the resistance, roughness, something like very large of a variable to influence the FFR value itself. And so, a total perception, treat or not treat, I prefer FFR.
I'm with you.
But I hope as you know that the FFR was derived from the non-invasive stress test first.
Yes,
right?
yes.
So stress test positive, that was the variable that determined FFR value. Isn't that right?
Yep.
Anyway, so I think it may be helpful somehow non-invasive stress testing. Using not just the wall motion, but the strain imaging and other, sophisticated technique to evaluate the wall motion ischemia before you guys doing FFR,
yes,
and then you
agree.
show that this is the area that you're gonna get FFR. I think would be really fantastic, right?
All right, really, thank you for nice discussion and nice brief for interviewing, and really thank you for joining us again. Right.
Thank you very much.
Thank you.
Our pleasure.
Thank you very much.
Thank you.
Yeah.